Thank you. I hope you don't get bored from my voice. There's one more at the end. So this one is going to be about pediatric aortic surgery, particularly mid-aortic syndrome. And I know not many people do aortic surgery apart from a bit of trauma. And it is because volume. We are the second highest volume in UK and probably one of the biggest guys in St. Thomas's because we have Evelina London, our pediatric hospital attached to us, but that means 1 or 2 elective mid-aortic syndrome operative cases a year. This is high-ish volume. Great Ormond Street do a little bit more than us, and that's it, really, almost. So for the Americans in the room, I know that they have higher volumes than this, so experience is quite difficult with those ones. Mid-aortic syndrome is, in most patients, they have stenosis of more than one major vessel. And 36% of them have additional associated syndromes. Neurofibromatosis is the most famous. Medical, radiological, or surgical management, 8% mortality is reported in literature. Biggest series is from Dr. Stanley in Michigan. This is the biggest contemporary one. Freedom of reintervention, 58% versus 83% with surgery. Endovascular can delay surgery until appropriate age. So the current approach is to try endovascular without burning bridges until you get the kid into good enough size to operate. What makes it difficult is that it is rare. Threshold for intervention is quite tricky and needs a lot of discussion, whether it is end organ ischemia like deteriorating renal function or refractory blood pressure. Difficult and late diagnosis in many where they present with multiple other congenital issues. They have multiple comorbidities and they are technically demanding. Lack of evidence and limited literature make you kind of plan the operation with what you have. And then less open repairs and less expertise are now available. So fewer surgeons are doing them, and we will see what will happen in the future with those types of surgery. This is just to show you that the majority of them present with hypertension. This is a meta-analysis. You can see the numbers are not very high in this series, but hypertension has been the first and the most common clinical feature for those kids. And in reality, every hypertension kid that you do not have a good reason for them, they should be suspected to have mid-aortic syndrome. Classification, this is diagrammatic to show you the different type depending on where the stenosis is. And as we said, you can have sometimes a bit of the aorta stenosis, but also some origin of the celiac SMA or renal, and that can complicate things. Some of them already, by the time they present, they have one kidney gone, and the other one is running on a stenosed renal artery. A couple of cases to go through. This was an 18-month-old child, very early. I think that was probably around 10 years ago now. A full term, no antenatal concerns, unwell with fever and diarrhea, hypertensive with a blood pressure of 210 over 120 and hepatomegaly, hypertensive cardiomyopathy and renal impairment. You can see the heart is taking most of his chest here. And you see the mid-aortic syndrome. I have to say the aorta itself had a bit of a waste, but the main problem was his tight renal artery for a single kidney. We ended up, he's 18 months, so we were quite not too excited to operate open. Tried endovascular once, twice, and then the third time I remember very well, went to the MDM and we pushed one of our intervention radiologists to use a cutting balloon. This renal artery was 1.2 millimeter, and unfortunately it has thrombosed on table and ended up with a single kidney thrombosing on table. All of this was lost and a run done and nothing you can see. So we ended up taking him for an emergency auto transplant, did a midline, took the kidney out, prepared it on the bench with pediatric transplant surgeons, and found one branch gone completely and the other two, the bifurcated, put it directly on the aorta and IVC, and ended up with a salvage kidney without the upper pole. He's now 10, still with a kidney, not on dialysis. And I think that was a good one. The two controversial bit was, I think the lessons learned here was, the cutting balloon was a little bit of overdoing. And if you have to do it, you have to have the surgical team on site, ready to do an auto transplant, because this is a very high risk for a stenosed one. The second thing is the multidisciplinary team and the discussions prepared us that that this is pushing the limit. We consented the patient and counseled, and he already knew, and the parents already knew that he might be dialysis dependent. And the last thing is warm ischemia time of 1 hour 50 minutes within the 18 months old boy. Then another hour and a half cold ischemia time with flushing, and he was peeing on table with the auto transplant. We put it on the aorta, and then we ballooned the mid-aortic syndrome segment later on to allow more inflow, and it responded well, so we didn't do anything to the visceral segment. His sister has the same problem, so we will deal with that later. Another one who's a 3-year-old presented with failure to thrive at 18 months. Hypertensive crisis in 2021, mid-aortic syndrome, ASD, pulmonary branch stenosis, Alagille syndrome, which I didn't know much until I read about it, and right multicystic kidney that is not functioning, and the left one with a severe stenosis. Presented with a minor stroke, fully recovered, hypertensive one. Then a decline of the renal function, and a fully recovered, multiple angioplasties, recoiling either on table or within a week. So another one that might, I hope this is going to work, this video, yeah, it should. Oh, that's sad. Can this work? Okay. So the mid-aortic syndrome was 8 millimeter descending thoracic aorta, then it goes down to 2, and then it comes back to 6 millimeter in the infrarenal. So the visceral segment was 2 millimeter only as a maximum diameter. Single kidney, left side, stented left renal artery, unfortunately, because it dissected in the last angioplasty. So we ended up with a single kidney with a stented left renal artery and a 2 millimeter mid-aortic segment, and a complex post-medical history. We went on, we had good experience with 3D printing in terms of planning. We went on and done a 3D printing, and this was the stent, the mid-aortic segment, just to familiarize with the size and with the anatomy. And we decided we will go for a full correction, which is basically a patch to the visceral segment and a jump graft from the infrarenal to the left kidney hilum, using a long saphenous vein. And this is a bit of the planning beforehand. And you can see the size is a bit small. This is real size 3D printing. And ended up with aortic patch. I used a pulmonary cadaveric one, a fresh one from a young patient, and an auto-transplanted left kidney to the distal aorta. It's actually not really an auto-transplant, it was a jump graft. I hope this one works. Can this video work, please? No? Okay. So if it doesn't work because we don't have much time, this it's working. You see, this is the patch. SMA is here. Left renal is coming from now the long saphenous vein from here. This is the hilum of the left ventricle. The thoracic approach and the long saphenous vein is probably the bigger than the renal artery at the end. And the 2 millimeter is now 6 millimeter on CT scans. And you can see here the outcome. I left the stent in place. There is a bit of a stenosis here, I think, but on duplex it's not a significant one. And the mid-aortic syndrome is completely sorted with no gradient so far. And the outcomes and the lessons learned here was we need to kind of do a lot of long-term surveillance for those ones. I think she might re-stenose, and we might need to do a bit more. We thought of the second and the third stage, so we left the stump of the renal artery for an auto-transplant. Those cases are quite hard, they are rare, and we have to consider all of this to get the best outcomes. Thank you very much.
Thank you, Dr. Sallam, for this presentation. It is a challenge to work in pediatrics. Next is Dr. Hassan Tani from